study beta blocker poisoning. Background: a 27-year-old female weighing 60 كيلوغرام suffering acute depression swallowed 70 في 40 ملغرام بروبرانولول تابلت، أي بما يعادل 2.8 جرام with suicidal intent. Physical examination: initial fetal sign: heart rate 46 ppm, blood pressure 100 إلى 60 mmHg. Diagnostic test: ECG shows sinus bradycardia of 46 ppm with PR interval 210, QRS duration 115, QT interval 380 and small R wave in AVR of approximately 2 in height. Test result: the test result lower in blood pressure and slow in heart rate. What type of drug is propranolol? Propranolol is liquid soluble, non-cardioselective beta blocker acting on beta 1 and beta 2 with sodium channel blocking effect. The toxikinetic of propranolol: absorption: rapidly absorbed orally. Peak blood level أقل من ساعة إلى 3 ساعات following oral administration. Distribution: highly lipophilic agent with a wide volume of distribution, rapidly distributed to L tissue including CNS. Protein binding: approximately 93% protein bound. Metabolism: undergoes extensive hepatic metabolism with hydroxylation of the aromatic nucleus and degradation of the isoprenaline side chain. Over 20 metabolite identified. The 4-hydroxy metabolite has active beta blocking properties. Elimination: 95 إلى 100% of an ingested dose is excreted in the urine as metabolite and their conjunctives. Half-life: a plasma half-life is around 3 إلى 6 ساعات. The pharmacological effect lasts much longer than this. Elimination half-life is 12 ساعة and may be prolonged following overdose. Mechanism effect: propranolol exerts its toxic effect via two main mechanisms. الميكانيزم الأولى هي بيتا أدرينرجيك ريسبتور بلوكيت بيتا 1 and بيتا 2 ريسبتور. أما الميكانيزم الثانية هي صوديوم channel blockade. Competitive antagonism of beta receptor led to decreased intracellular CAMP with the blunting of the chronotropic and inotropic and metabolic effect of catecholamine. Sodium channel blockade in the myocardium led to prolongation of the cardiac action potential with resultant QRS widening and potential for ventricular arrhythmias. Blockade of sodium channel in the CNS produce neurotoxic effect, seizure and coma. What the clinical feature of the propranolol overdose? Excess beta adrenergic blockade causes hypotension and bradycardia, bradyarrhythmias including sinus bradycardia من درجة إلى 3 درجات heart shock, heart block, conjunctional or ventricular bradycardia bronchospasm hyperkalemia and hypo or hyperglycemia sodium channel blockade causes بالcardiotoxicity QRS widening ventricular arrhythmias and cardiac arrest بالneurotoxicity coma and seizure and delirium massive propranolol overdose typically present with coma and seizure and bradycardia and progressive cardiogenic shock. What is the lethal dose of propranolol؟ الجرعة المميتة من البروبرانولول. Any ingested dose of propranolol أكثر من 1 جرام is considered to be potentially lethal. Hence, this history of 2.8 gram ingestion is extremely worrying. How should this patient be managed? Propranolol overdose is managed primarily as a tricyclic antidepressant overdose, as early life threats are due to its sodium channel blocking effect, and secondarily as a beta blocker overdose. Operative care and monitoring. This patient needs to be managed in a monitoring area equipped for airway management and resuscitation. Suture IV access administer high flow oxygen and attach monitoring equipment. Treat seizure with IV benzodiazepine مثل diazepam بجرعة 5 إلى 10 ملغ. Insert an arterial line for close hemodynamic monitoring. Perform serial 12 lead ECG to assess for sodium channel blockade QRS أكبر من 100. Management of sodium channel blockade. Administer IV sodium bicarbonate 100 MEQ 1 إلى 2 MEQ لكل كيلو. Intubate as soon as possible. Hyperventilate to maintain a pH of 7.5 إلى 7.55. If ventricular arrhythmias occur, the first step is to give more sodium bicarbonate lidocaine 1.5 ملغ على كيلوغرام. IV is third line agent after bicarbonate and hyperventilation. Once pH is أكبر من 7.5. Unestablished cardiotoxicity. The dose of sodium bicarbonate can be repeated every few minutes until the PP improve and QRS complexes begin to narrow. Avoid IA, prosinamide and IC, flecainide, antiarrhythmics and amiodarone, as they may worsen hypotension and conduction abnormalities. Management of bradycardia and hypotension. Treat hypotension with initial crystalloid plus 10 إلى 20 ml على كيلوغرام. If this is unsuccessful in restoring PP, be prepared to rapidly escalate to more advanced circulatory support using entropies and chronotrope. Atropine 10 إلى 30 مايكروغرام على كيلوغرام can be used as temporizing measure for bradycardia. Persistent bradycardia and hypotension is better treated with a titrated infusion of adrenaline or isoprenaline via a central venous catheter. If anatropes are required, consider early initiation of high-dose insulin euglycemic therapy, as described in toxicology conodron. This treatment appeared to be very effective in massive propranolol overdose, but take time to work 30 إلى 45 minutes. Glucagon is considered to be the antidote to beta blocker poisoning. Is no longer recommended as it is difficult to source in adequate quantities and offers no advantage over standard inotrope and chronotrope.